Okay, hello everyone. Welcome to session 11 of the Oxygen Therapy and Critical Care case-based series. Today's topic is referring patients to a higher level of care. Welcome, thank you for joining, and as usual, we have the session being led by Dr. Eugene from the Institute of Medical Education and Global Health, and with us Dr. Jean-Paul from the University of Rwanda. And so with that, I'll pass it over to Dr. Eugene to get us started.
Thank you very much, Arana, for introducing the session. And thank you for everyone for joining us. I think this will be an interesting session and it will be interactive. I'm happy I will be with Jean-Paul as well, who will help to guide the discussion. Jean-Paul, if you have anything to say, go ahead, please, and then we'll start in a few seconds.
Good evening, everyone, especially those who are in Rwanda. We are at the evening, and I'm very excited to be with you, all of us, in this interesting session. I don't have much to tell, so we can start. Maybe I'm still connecting on my computer to, I think Eugene can start maybe the few first minute, and then I will take over. I'm still connecting.
Yeah.
Maybe in 5 minutes I will be ready to take over.
Yeah,
I'm opening my PowerPoint. Okay.
No problem, Jean-Paul. This will be interactive, just sharing experience, because everyone who is joining has experience with this type of patient. So as you know, the title for today is the escalation to a high level of care. In other words, how do we decide to call in other teams or probably transfer patients who are critically ill, especially in this context of COVID-19? So here are the objectives for today. So by the end of the session, we should be able to develop decision-making competency about when to admit patients to the hospital using the triage protocols and the hospital admission criteria. So everyone now you can think about existing triage protocols and the hospital admission criteria. We should be able to define mild, moderate, severe, and critical illness from COVID-19 so that we can decide the appropriate management. And then we should be able to develop decision-making competency about how to design isolation areas for patients with suspected COVID-19. So we'll share some resources which can guide you to see if we're meeting international standards for isolation, and we can share experience of the current practice in order to protect patients, but also to protect healthcare providers. After that, we should be able to design and follow protocols for escalation of oxygen therapy, which I think you are the expert now. We have done more than 10 sessions around this. So we should be able to decide when a patient needs to be evaluated by a senior physician. When do we call for help? We should be able to decide when a patient needs to be evaluated by ICU teams, or if we don't have ICU teams, we should be able to know when to transfer and do a safe transfer for these patients. We should also to be able to recognize how critical care can be provided out of the ICU. Lastly, we should be able to understand when to refer the patient to high level of care within the context of the available resources in our hospitals. So in order to do that, let us start with a case. So you have a 36 years old male who presents at the emergency department with 2 days history of fever, cough, and shortness of breath. In the emergency department, the patient was screened for COVID-19 risk factors and the patient was isolated from other patients and is wearing a face covering. You arrive to evaluate the patient and realize it is your colleague. You are wearing a PPE for contact, droplet, and airborne precautions. The patient admits he is short of breath, has fever and a cough, but denies the loss of taste and the smell. Here are the vital signs. The temperature is 37 degrees Celsius. The blood pressure is 110 over 74. The heart rate is 94. The respiratory rate is 18. And the SpO2 is 92%. Then you press the patient on oxygen 5 liters per minute by nasal prong before taking a history and performing a physical exam. In past medical history, he's healthy, but had a history of bronchitis in the past. He had inguinal hernia repair in 1988. He's not taking any medications. Family history, the mother died and he had a history of hypertension and diabetes. The father also died and he had a history of emphysema. He has one sister who is healthy, and he has two children who are healthy as well. So as a social history, he works as a general practitioner physician. He doesn't smoke. He doesn't use any illicit drug or alcohol. Otherwise, no other symptoms. On a physical exam, the patient is alert and is moving all limbs, and also the pupils are reactive to light and are equal. On an airway exam, his myopathy 2, normal range of motion of the neck, and the dentition is intact, and environmental distance is 6 centimeters. Cardiovascular exam, the, he has a normal pulse and a normal rhythm and normal rate. The capillary refill time is below 2 seconds. He has coarse breath sound. He has tachypnea now. So the heart rate is 32 beats per minute, which is high. Normal exam on the abdomen, and he has level 2 or edema on both limbs. So the skin is normal. So here is the question. Would you admit this patient to the hospital, or you would manage this patient at home? Do you think the patient has mild, moderate, or severe disease? So let's answer those questions in the chat. You can put patient to be admitted or managed at home. That's the first question. Choose between those two and then decide if the patient has mild, moderate, or severe disease. You can put mild or moderate or severe. So you have 30 seconds to answer that before we see in details uh, the definition for mild, moderate, and severe disease. Yeah, let's try to be interactive so that we see if we are following. I think you remember our patient. Okay, Claude is answering that the patient has a severe disease, therefore he should be admitted to the hospital. So what other people think? Yeah, because this is like an important question. Whenever we see our patient, we need to think, what is the disposition of the patient? What is the plan? Okay, Theogene also said, admitted to the hospital, he has severe disease. So wait for two more answers and then we can proceed. Yeah, here is the vital signs on arrival. So the blood pressure was okay, was normal, heart rate slightly increased, the blood rate slightly increased at 18, SpO2 around 92%, and the symptoms fever, cough, shortness of breath. But remember, at the emergency, things changed. The respiratory rate increased to 32 here. Okay, that's good. Let's see the answer. Very good. So I think I agree with most of your answers. So the patient has severe disease. So let's see how we classify COVID. So the patient may be asymptomatic. If someone just, like you are going to travel, they do the screening and you are COVID positive, but you have no signs of symptoms or symptoms. You are asymptomatic. You may have COVID, but you are asymptomatic. That's the first stage. Or you have mild illness. So you have like common symptoms, but no shortness of breath. So that's what you have to think about. Is there any shortness of breath? So, and then if someone has just fever, cough, sore throat, malaise, headache, muscle pain, nausea, vomiting, diarrhea, non-specific symptoms, that may be a mild illness. And this patient may be managed at home. But once you have shortness of breath, you put a pulse oximeter, and then you decide, is SpO2 above 94%? If it is above 94%, then the patient has a moderate illness. Still, you need to have that patient in the hospital because they are at risk of having a severe illness where SpO2 is below 94%. Okay? And that means that the PaO2 to FiO2 ratio is below 300, or you need a lot of FiO2 in order to achieve a PaO2 of around 300. And usually respiratory rate is above 30. Remember, the normal one is between 12 and 18. So this patient has a severe illness, as you remember, because the heart rate, the respiratory rate was above 30, and also SpO2 was below 94. So critical illness, once you have respiratory failure, we'll see what the definition of respiratory failure in the next slide, or you have septic shock or other multiple organ dysfunction. Okay, remember that there are patients who have increased risk of COVID, including elderly patients, patients who are immunocompromised, diabetes, with diabetes, or who have also cardiac diseases, just to cite few. Okay, I think that's clear. So let's think of our next objectives. How do we develop protocols for admission for this patient? And we should be able to do education with two other healthcare providers about mild, moderate, and severe illness. And I think with what you have seen with this previous question, we should be able to achieve that. So our next goal is to do a good isolation for this type of patient. And before we share the resource, because I don't think we have time to go in details of airborne infection isolation room, um, we, we, we need to know if we have that option in our hospital. So maybe you can share your experience in the chat. Do we have like airborne infection isolation rooms? For example, for patients with TB or patients with COVID? So you can put just in the chat if you have an isolation room at your hospital. We have an isolation room available. And then after that, we open the link there and discuss. Arana, you can open the link. Yeah, go down. Yeah, that's good. That's good. Yeah, as you see, usually airborne infection isolation room was called negative pressure isolation room. And here it is defined as a single occupancy patient care room used to isolate persons with a suspected or confirmed airborne infectious disease. Environmental factors are controlled in these rooms to minimize the transmission of infectious agents that are usually transmitted from person to person by droplets associated with coughing or aerosolization of contaminated fluids. So these rooms should provide negative pressure in the room so that air flows under the door gap into the room and airflow rate of uh, and also the direct exhaust of air from the room to the outside of the building and the circulation of air through filter before returning to the circulation. So there are technical terms that are not familiar with me, but all we need to understand is that um, the the air from the patient should not be in contact with anyone else. So it should go through um, a negative pressure and then go outside the room without like being in contact with someone else. So, and we need to involve environmental officers in our hospital and infection control specialists to make sure that our isolation room meet, meets those standards. And in the case we don't have those isolation room, the recommendation is we need to open the windows, open doors, and we can use regular fans. Yeah, yeah, that's good. So we'll be able to, you can have more information on this highlight from chapter 15 to chapter 38. Um, And we'll share also the slides with examples of the funds you can use. Usually those are regular funds. I don't know if that is clear, but I don't expect us to be the expert for, for the isolation rooms. We need to have other team members in the hospital involved. Jean-Paul, do you have anything to add on that?
Yes, thank you, Eugene. If you allow me, I can comment a little bit about the previous talk on the protocols regarding to severity classification, mild, severe, and the moderate, especially for this patient of COVID. This is really a key point and in our practice change. All of us who are attending this course, we are coming from different hospitals. So you have to be the front line, you have to be the one for changes and the impact change. If you are working in a hospital and there isn't this classification, like someone who attended this course, you have to work with the IPC team, with the infectious emergency doctors, and then sit with them and develop this protocol so that you may not miss someone who came in severity and then you discharge the patient, like someone will be observed at home until he has this sign of severity. If you have like a protocol and you can put it on the walls of the emergency, which is very easy to read for anyone, it can help to save someone's life. This is something really very important for all of us. So that's one. I guess everyone can have that exercise from where he's working. And I know this period, all of us, anesthetists, nurses who have been involved in COVID care management. So you may advise your team that there is a simple way, if you don't have that protocol, and sit with them and start developing that protocol. The second was regarding to this isolation, where they recommend that negative pressure. I'm not sure from my experience of this hospital I'm working at, Butare University Hospital, we don't have such room. But what I know, we have isolation room for tuberculosis. Even most of the hospital in Rwanda, they have isolation room for tuberculosis before. Now, most of these TB rooms came isolation for COVID. Those rooms, they don't have negative pressure. So at least, as they said, there is an alternative, like having fans there. You can open the doors, the windows, my colleagues knows that the national guideline of COVID prevention measures, now they are recommending to open doors when people they are sitting around, so that there is a way of ventilation, enough or adequate ventilation. If you are in the cars, you have to advise them to open up the windows so that you can have adequate ventilation. So it's the same in the hospital. The simple way we have is to open the doors and the window, and also they can put ventilation. And we have ventilation is a simple ventilator who can use as a ventilateur in French. So, or furnace. This is how our system is built, and that how we are working on it. That was my comment.
Yeah, thank you very much, Jean-Paul. So the other thing we need to think about, those patients in isolation room, they will have to keep their mask on. And if you go in, you consider putting N95 mask on if those masks are available for your own protection, as we're still working on our system to have those negative pressure rooms built. So any question from that? I don't think we covered all of the aspect of isolation rooms, but we discussed the key points and we share the content of the book if you need more resources. Okay, let's continue with the next objectives. Um, After this discussion, we should be able also to assess isolation protocols in our facility. We should be able to know where the isolation rooms are and understand how physical distance and the ventilation can protect patients and the healthcare providers, and ensure the education of all healthcare providers regarding isolation and the ventilation. So I think we have achieved that.
Recording in progress.
So let's continue. Here is a quick question. So we have already diagnosed our patient with COVID-19. So what other additional investigation will you order or will you ask for? So you can put that in the chat. What are the other investigation will you ask? So to make it simple, think about laboratory investigations and imaging. So what types of investigation will you ask? In the laboratory, what are the investigation you will do ask? And for imaging, what are the imaging investigation will you ask? So we'll give you like 45 seconds and then we'll discuss that. I don't know if the question is clear. So what type of investigation will you ask? Is there FBC? That's just an example. Or creatinine, those are labs. And then for investigation, do you need a CT scan? Do you need, those are example of imaging. Okay, Jean said ABG, chest X-ray, ectorite, FBC. I don't know if for Jean Leonard they have ABG in their hospital. Let's wait see what other people will order. Okay, so I think I've seen some of the answers. What I see, most of the people would ask for chest X-ray for imaging, and FBC and electrolytes and ABG. So let's see what we ask in our context. What is recommended? Um, I don't think we need to, I don't know, we don't need that because that's a detailed X-ray. Um, but we have the information on our PowerPoint, which we will share of the common investigation requested for COVID. So I will just summarize what common investigation are requested in high income settings, but most of them are not available in our context. So for labs, you may consider inflammatory markers. As you know, in the case of COVID-19, there is increased inflammation. So therefore, you may ask for inflammatory markers, including D dimers, which will be increased to more than 1,000 nanogram per milliliter, CRP, um, LDH, troponin, which may be double the normal of troponin, ferritin, and creatine phosphokinase, which will be increased. So I don't expect to ask this in our context, but we have CRP in our context, I think. So those are the common inflammatory markers. But on top of that, we ask regular investigation, obviously FBC, where you are concerned to have lymphocytosis because of increased inflammation and sometimes thrombocytopenia, so or low platelets. So FBC, you can ask also electrolyte and creatinine and urea for baseline kidney function, and also ASAT and ALAT for baseline liver function. So those are the common labs. And then if you are in the facility where you have the CT scan, you can ask for CT scan where you will look for bilateral lung infiltrates. And also you can ask chest X-ray, as you say. Those are the common investigation. And we will share all of those for um, with our PowerPoint. So just keep in mind that if the patient is old, you can consider asking EKG as well, as you can see fit. So that's just a summary of the common investigation. But the best way is to check on the existing protocols from RBC or from your own hospital to meet the local context. Jean-Paul, do you have any addition to that?
as you said,
We can't hear you.
hear me?
Yeah, go close, yeah, to your mic.
Arana to let me close one.
We can't hear you. Okay, so we wait until we can hear Jean Paul, but if there is no question about investigations, we can continue. So you remember our patient is admitted to the hospital and he has been transferred to an isolation bed. So he is on 5 liters of oxygen by nasal cannula. And when he arrives on the ward, the nurse obtains another set of vital signs. So the heart rate is 99, the blood pressure is still normal, 103/60. The respiratory rate is increased at 28. And SpO2 has decreased to 89%. Temperature is at 8.5. So, and that brings us to the next question of escalation of oxygen therapy. And I think you are the expert now. So, what do you do? So, the patient is already on 5 liters of oxygen by nasal cannula. So, what is your next uh, plan for oxygen therapy for this patient? So, put in the chat how much oxygen and by which tool will you use or which device will you use to give more oxygen to this patient. We have 30 seconds. Okay, yeah. Someone saying mask of no reservoir, but how much oxygen? 10 liters per minute. Okay, it's good. Yeah, while waiting for others, we can click on this page where we have a summary of escalation of oxygen. Yeah, this table, I would like to look on that table. Yeah, if we can increase the size. Yeah, that's very good. Yeah, here is just a decision tree, which help us to know what to do. But you ask the first question, if the patient has hypoxia, what type of hypoxia? Do you think the patient has a risk of hypercapnic respiratory failure? If your answer is yes, you go on the left and you see if SpO2 is below 88. And if it is very low, then you give 1 to 2 liters per minute by nasal cannula, uh, or 2 to 4 liters via venturi mask. And you need to achieve SpO2 of 88 to 92. But our patient doesn't have risk of hypercapnic respiratory failure. So those example of those patients are obese patients, for example, and patient of chronic COPD. So because they have a high retention of CO2. So that's just an example. And if there's no improvement, you can always go to non-invasive ventilation or consider intubation. So on the right side, where our patient is, so our patient is in here. So because SpO2 is below between 85 and 91, start 2 to 4 liters by nasal cannula. You have done that, and PaCO2 is below 45. So you need to be able to monitor SpO2 and increase your oxygenation until you have a goal of 92 to 96. This is your target. And you can do that by increasing your flow of oxygen. You can give 5 to 10 liters by mask. And if that doesn't work, you can go up to 15 by mask with reservoir. And over time, you can consider non-invasive ventilation, which is not usually available. And if you think you need to transfer, you may consider intubation and transfer for ICU and ventilation. So I don't know if Jean-Paul has any addition to that, but I think the idea is to increase your flow of oxygen and changing the device until you achieve your goal, which is usually between 92 and 96% of saturation.
Yes, Eugene, thank you. Do you hear me?
Yes.
Okay. So for this session of oxygen, for this patient, we've been discussing who I can comment a little bit, like 1 minute of the previous one you've asked me. I had a comment that was about the laboratory investigation. As you said, this is depend on the hospital laboratory capacity and the imaging capacity each hospital have, but it's also better to have like a protocol to consider the national COVID treatment protocol, and the hospital, for us who are working in the hospital, the committee can sit and develop a protocol in order not to miss any important laboratory workup which is being done in the hospital, and depend on the clinician choice. Someone can say this is important, another doctor may think this is not important. But if like we have a written protocol, I guess it's better everyone can follow the protocol in order not missing anything. Again, as you mentioned, not many hospital which has the CT scan capacity or heart ultrasound, not many hospitals. But in the COVID patient, where the CT scan is available, like here at Hashibe, I have been seeing that some of the patients, they have the thromboembolic disease secondary to COVID. Some of them we've been performing like chest or CT angio. So this is also very important. So coming back to the oxygen therapy for this patient who have been on nasal cannula. As you mentioned in the beginning, we've covered, and I think all of us, we are becoming expert how we can choose a device, oxygen device, according to the patient we are having. So of course, not many hospitals are having the same device. Like the patient was on nasal cannula. Most of them have seen their answers who shifted on facial mask, who shifted facial mask, then later on facial mask is reservoir. All depend. We all should remember what will the FiO2 this device is delivering. If your device you started with is not
raising up the oxygen saturation of the patient. That means the patient is not coping with that device. Then move to the next one, which could deliver the high FiO2 so that you can at least achieve the desired oxygen saturation up to the point where you will decide to intubate a patient. Mechanical ventilation will be the last option if the patient will remain hypoxic. You've tried all the oxygenotherapy measures you have or available in the hospital, and the patient still hypoxic, then the last option will be the intubation. There is another device which is nasocannula high flow. I don't know if our participants have got a chance to see how they are working, especially this new COVID center. We do have it, like here at Sashibe, in the COVID treatment center, we have high flow nasocannula, where we go to the flow of 60 liters per minute. So our participants who are from Sashibe or others, it's really very interesting to visit and see those high flow nasocannula, how they are working. So that was the key message transmitted to them. It's better to come and see. They are really very wonderful. So that was my comment, Eugene.
Thank you very much. Yeah, we can go back to the main slide. Yeah, I think this is a summary of what Jean-Paul has discussed. So those are the options you have. You have nasal prongs. You have also non-rebreather mask. You have a mask for CPAP. You have a venturi mask, which is not always available, and you have high flow nasal cannula, and you can do intubation. So we don't need to spend much time on that. So there are specific considerations we need to think about, especially pregnant women and patients with COPD. And we'll see in details what you have to do for that. And we have already done this inventory of devices available in our facilities, and also escalation of oxygen therapy. I think we have covered most of this. I don't know if people have questions, but for pregnant women, you know, they have increased oxygen demand. So you will decide to give oxygen earlier. If you see a pregnant woman with COVID and the SpO2 is below 94%, that's the time to start escalating oxygen therapy. That's the change for that. And for COPD, you know that these patients, they are always having a high CO2 retention. So, and they're chronically hypoxemic. So the target usually for healthy patient of SpO2 is 92 to 96. For them, the target may be lower. So you can allow SpO2 or as low as 88 to 92. That's the only difference for those two examples. I don't know if Jean-Paul has any addition to that or someone has a question.
Maybe if there is a question, we can go through the question. If there is no question, we can move to the next.
Sure. Yeah, and this is a simple question. At which level should we call for a senior doctor? So there is an answer, but I don't know for people their own experience. When do you call a senior doctor? At which oxygen level, at which saturation would you call a senior doctor. You can put that in the chat. Is when you give like 5 liters, 6, 10, is there a number? But for this particular talk, we have a cutoff where you have to call a senior doctor or call ICU if you are escalating oxygen therapy, which means that the patient is getting much risk of having a severe disease. Okay, I see people are very quiet, but we can click on that. But the answer is once you increase oxygen therapy to more than 6 liters, then it's time for calling for a senior doctor. As you can see here on number 7. So if FiO2 is above 40%, or you are giving more than 6 liters per minute, very simple filtration mask, you need to call a senior physician. And once you go above 80 liters, you need to call ICU when ICU is available. But in our context, you need to start thinking about what will be the disposition of this patient if the patient gets respiratory failure. Where am I going to send this patient? Do I need to start getting a spot for ICU in the teaching hospital? Those are the type of questions you should start thinking about. Or do I have all the enough oxygen to transfer this patient from my hospital to the other hospital? Is the ambulance available? So just start thinking those type of questions. So let's go back to the main threads. So for the awake prone positioning, I think we have discussed that before. I will not go in much details. We have the link available, but just consider, think about indications, contraindications to prone positioning before you do that. And for awake prone positioning, there are common contraindication to think about, especially if the patient is hemodynamically unstable or the patient has impending respiratory failure. Okay, so let's continue with our patient. So on the physical exam, the patient is still alert and the neurologic exam is normal. We have seen the airway exam, nothing has changed. And then is this patient in a respiratory failure? Because you see the respiratory rate is 32 beats per minute. What do you think? You can put that in the chat. Do you think this patient is in respiratory failure? And if you know, what are the common types of respiratory failure? we give you 1 minute to think about that and put the answer in the chat. Okay, people are very quiet. Do you think the patient is in respiratory failure? Yes or no? That's a simple question. You can put that in the chat. And then probably which type of respiratory failure? That's a simple question. We'll give you 30 seconds and then we can answer that. Okay, people are very quiet. So let's help to answer the question. Maybe, I don't know, you can click on that. So there are 4 types, common types of respiratory failure. And I agree, this patient, as Patrick said, is in a respiratory failure. So let's start with basic definition. So as you know, you need to be able to do oxygenation or like giving oxygen to the tissue, but also like removing CO2, which is ventilation. So respiratory failure may be involved in those 2 mechanisms. So type 1, it means you are not able to give enough oxygenation, and that translates to partial pressure of oxygen below 50 on room air. And the common examples are pulmonary edema and acute lung injury, or ARDS, as you know that. We have discussed that before. So these disorders, they interfere with lungs' ability to oxygenate blood as it flows through pulmonary vasculature. For type 2 or hypercapnic or ventilatory respiratory failure, you have issues of removing CO2. And the number to think about is 50 as well. So if CO2 or partial pressure of CO2 is above 50, then there is also an increased work of breathing due to the common cause is airflow obstruction or decreased respiratory system compliance, or there is decrease in power of the neuromusculature or problem of neuromusculature disease, or we have a central respiratory failure. For example, we have too much opioid, or there is brain injury, or a decrease in respiratory drive. So there is a whole list below of etiologies. So for type 3, it's perioperative, and this is very common, and this is important to most of the people following who are doing anesthesia. So usually this usually part of the type 1 failure, but we consider it separate because it's very common. And the last three, you have respiratory failure from cardiovascular instability or shock. You can go down and show them some of the examples, but they have access to the resource. Go down. Yeah, that's good. So, and as you can see, there are etiologies for type 1, where you have issues of neuromuscular diseases like Guillain-Barré syndrome, type 1, go down. Yeah, we have examples of cardiogenic pulmonary edema, ARDS, pneumonia, lung hemorrhage, atelectasis, which is common in surgery as well. And type 2, you can go down. We have issues of decreased maintenance drive, as we discussed, drug overdose, neuromuscular diseases, asthma, COPD. Yeah, those are common examples. And we go to perioperative, so we can go through here because this is very common. So when you have decrease in FRC, supine patient, obese, ascites, after anesthesia, upper and abdominal incision, those are common causes of atelectasis. So just think about that, and then think about shock. When you have cardiogenic shock, hypovolemic shock, or septic shock, even if the blood is oxygenated, but the heart can't pump enough blood to all the tissues. Okay, that's common examples of respiratory failure. I hope that was helpful, and you have access to the resource. So we'll skip this question of like the clinical signs and symptoms of respiratory failure in adults, because we have seen it before, and I think there's a video you can watch. Just remember the common signs of respiratory failure in adult. I think we have access to the video. Okay, because you have already shown it, you can like play the video. They can see this patient in respiratory failure. And they can describe what we see. You can see use of the accessory markers. They are study the reflection. Use of abdominal muscles as well. So, this is just an example of a patient. You may have also some of the question. Thank you, Alan. I think that's enough. Jean-Paul, do you have an addition to like how to think about respiratory failure, especially in adults? If you have something, please feel free to add on that.
So I don't have much comment, and I think you've clearly explained it,
Okay.
everything regarding to respiratory failure. You you can keep moving forward.
Yeah, we're almost at the end because was a short session um, with a focus on how to the escalation of oxygen therapy in the context of COVID. Um, so, and at the end, I think we are able to do these objectives. So we think we should be able to recognize um, when we need to call a senior doctor, and especially when FiO2 is below 40. It's increased at 40%, or we are giving more than 6 liters per minute of oxygen therapy in order to maintain SpO2 above 90. I think we for the second one, prone positioning in a work patient, I shared the article explaining the ways and the evidence behind that. So the main consideration to think about is just to think about contraindications to that, and to bring patient back to supine if the positioning is not working, and think about escalation of care. We discussed about how to think about the need of ICU, especially when you need more oxygen, like patient on 8 liters per minute to keep SpO2 above 90. And we need to be able to think ahead and anticipate the need of eye care, especially in our context when ICU may be available outside of our regular hospitals. Um, we skipped this objective because I thought everyone has a good knowledge of recognition of respiratory failure in adults. So as we have seen the example, people may have subexpiratory retraction, increased the work of breathing. They can have a high, increased heart rate, respiratory rate, increased heart rate, and also decreased in GCAs. Um, uh, and with that, we need to think about the escalation of care. So again, I think we have discussed in summary admission criteria, especially for COVID patient. We have discussed how to define mild, moderate, and severe disease for COVID-19. We discussed airborne infection, isolation room, and some isolation strategies. We discussed ideas on how to involve infection control specialists and environmental officers in the hospital. We discussed how to use oxygen therapy in that context and the need of ICU. Um, for X-ray, I think that was beyond the goal for today. And for a work prone positioning, we have discussed that before. And I think everyone is able to identify respiratory failure. So this brings us to the end of today's session. If there is any question, you can put the question in the chat, or you can always reach us via WhatsApp or email. And so I will let Arana conclude the session for today and tell us the plan for the next and the last session for this year. Arana, up to you.
Yes, sorry. So thank you everyone for your participation in the session today. Thank you so much, Dr. Eugene and Dr. Jean-Paul, for your excellent teaching. If you would like to access this presentation and the resources that were shared afterwards, you can do so by creating a free account on the Learning Resource Center. I'll share the link in just a moment. And we also encourage you to join and ask questions in our WhatsApp group. So if you have questions between sessions and you'd like to get some advice, that resource is there for you. And just to conclude, I'd like to thank Project ECHO for making this program possible, and Dr. Anna Crawford from Stanford Global Anesthesia for her creation of some of these materials. And our last session is going to be held on Saturday, December 18th. We've done some work to compile the most frequently asked questions about oxygen therapy and critical care. And so we'll be doing a recap of all of those concepts for our final session. So we hope you will save the date and join us for that. And yeah, as Dr. Eugene said, if you have any questions, feel free to email or reach out to us on WhatsApp. Thank you.
Thank you very much. Have a nice weekend.